Good morning. So I'm going to talk about our cancer management challenges at Ocean Road. My name is Dr. Muya. So this is Ocean Road. I think you've already seen this picture so many times this week. My talk will be on the overview, the challenges, and the conclusions. So the statistic in Tanzania, we have approximately 6,000 new cases a year at Ocean Road. This have been already mentioned by Dr. Jerry, and the majority of our cancer patients present with late stages, and there's increase in number of patients of cancers. And when you're talking about cancer registry, it's actually now that we're starting it at Ocean Road, but there's no, in the previous we didn't have cancer registry. So these are the incidents with male, more for prostate cancer, and then in female is cervical cancer. This one is showing the increase in number of cancer patients as from 2005 to 2016, the number is increasing. If you talk about the cervical cancer, in 2005 it was about 879, and in 2016 there was about 2,081. So there was increase in number of cases. And there's a mortality profile. This is what we normally see. This is like a stage 4 breast cancer patients. So what are the challenges that we are facing? So I actually categorize them into diagnostic. So in diagnostic, we have a challenge in imaging in most of the district hospitals. Actually, most of the district hospitals, they only have X-rays and ultrasound, and they don't have CT, leave alone MRI and other imagings. There is also a challenge in immunohistochemistry. We have a very few number of pathologists to report for the cancer diagnosis, and we actually don't do molecular biology. We have this Moha's genetic lab, but I don't think everyone can afford that. We only do BRCA. They do BRCA mutations, but it's very expensive. I don't think anyone can afford, apart from those who are covered by the National Health Insurance. Another challenge is on treatment. We actually have very few surgical oncologists, and most of the surgeries are done by the general surgeons. When you talk about the breast conserving surgeries, that's like a kind of nightmare. Most of the surgery that are done is a radical mastectomy, not breast conserving surgery. Still on some of the cases like breast cancer or gastric cancers, when they do surgery, they don't put surgical clips, so you don't know where to boost when you have to. And then in terms of radiotherapy, as the other speakers have mentioned, we only have, for the time being, we still have 2D in our government hospital with only one 3D machine, LINAC machine, which is private, and still no one has, they are not yet taking the NHI patients, so it's purely very few private insurance and those who can afford to pay in cash. So it's become a very challenge on treating head and neck cancers, gastric cancer post-operation, and brain tumors. So most of the brain tumor after surgery, you either give them temozolomide or you just leave them for palliative radiotherapy. In terms of brachytherapy, we have brachytherapy machine, but you're only treating the gynaes, the cervical and endometrium. We don't have we don't do interstitial or intraluminal or prostate brachytherapy. In terms of targeted therapy, some of the targeted therapy they are being given by the insurance and national health insurance. So for only those who have the national health insurance are the ones that can get the targeted therapy, especially the Herceptin, rituximab, and Avastin. Anyone who doesn't have, like you in the Ocean Road, you have 2 clinics. There is a national health insurance clinic, we call it like grade 1, and the public one. So for the public patients, most of them, they can't afford to have those targeted therapy. So if you have a patient that requires to have a R-CHOP, so you end up giving them CHOP only. And another challenge is the late presentation. So the late presentation, it have different causes. It can be due to the patient factors. Maybe they are being diagnosed early, they are told to go to Ocean Road, but they cannot afford to go. They are from very remote areas. Or because of they have very low knowledge of the disease, so they end up going to the traditional healers, and then only to show up at the very late stages. Another problem is late referrals. So some of the clinics, either private or even government hospital, they see the patient and they start treating, like if let's say it's a CA cervix, patient present with PV bleeding or low abdominal pain, PV discharge, they start treating as a infection, and then only to refer them very late when maybe they saw the patient at stage 1, and then patient is referred when it's all stage 3B. Another thing, as I said, the challenge is on the diagnosis. So sometimes we have wrong diagnosis, treating tonsillitis for such a long time, only to find out it's cancer. So some of the medical personnel, they have low index of cancer suspicion. So currently, actually from 2016, we have this project with the collaboration with the British Council and Royal College of Physicians in UK. So we have this train of the trainers. So we go in zones and train the medical officers to have a high index of suspicion of malignancies. So at least now it's helping. The project is still going on. Another thing is infrastructures. So as I said, the transport from remote area to where the treatment can be done, maybe it's either from Sumbawanga to Ocean Road. That can be difficult to some of the patients as they cannot even afford for the fare of the transport. Also, the number of cases we see for treatment, we have only 2 cobas machines, and we have so many cases that require radiotherapy. So we have a waiting list about 3 to 4 months now, waiting for treatment. And sometimes the machine breaks down. So there are so many things that we face in terms of infrastructures. And as I said, the private medical aid vis-a-vis national health insurance. So the national health insurance mostly covers the government employed, and very few that can get it as a private. And most of the Tanzanian, they don't have the private medical aid. Maybe it's like less than 1% who have a private medical aid. So again, the cover for treatment can be very difficult as well, especially for the investigation and, as I said, the targeted therapy. Another problem is the bed capacity and admission requirement. So at Ocean Road we have bed capacity around like 250 to 60. But the number of patients that we receive that they require, so the requirement of admission, it can be either because of the patient is from very remote area. So when they come to Ocean Road, they don't have any place to stay. So you have to admit them in the ward. And another problem is the patient can be in Dar es Salaam for treatment. I mean, they have relatives, but they're also staying far from Ocean Road. So the daily movement from home to get their radiotherapy, some of them they may get default because they cannot afford the fare to Ocean Road. So both of those, they need admission. Leave alone for those who are very sick because of the side effect of the treatment, either chemotherapy or radiotherapy, those need to be admitted in the ward. So those are also problems that we're facing. And the budget. Actually, Ocean Road is like 100% depending on the government budget. So as we know, it's not about Ocean Road only. They have other hospitals, they also need on the same budget that is sent to Ministry of Health. So that's also another challenge. So with our new LINAC machine at Ocean Road, that maybe will be starting from August, at least now we'll be able to treat the head and neck cases, the brain tumor cases, and the gastric cases. At least now we'll be in a good position of treating properly. And there is also another project on PET CT scan that is about to be sent in Ocean Road, but it's still on the progress. And yeah, the demand to have a functioning active multidisciplinary tumor board. We have a tumor board that oncology come from Ocean Road, they go to Muhimbili National Hospital to meet with this, but the tumor board, most of the time we have the surgeon, the oncologist, the pathologist, sometimes the gynae, depending if they have the case. But the problem is the tumor board is like a way of sending patient from Muhimbili to Ocean Road, not really to discuss what to do with the patient. So having the active multidisciplinary, that will actually change the way of managing properly the patient. Like you can find a patient with a T4 tumor and the surgeon has done radical mastectomy with a positive margin. So that's also another challenge. We have a cancer prevention and screening department. This one is actually doing a very good job on providing awareness on different cancers. We're doing screening on cervical, skin, and actually now they want to launch on the colon cancer screening. And the zonal hospital starting treating cancer. I think that one will actually reduce the number of patients that are seen at Ocean Road, and hence will also, maybe it will reduce the late coming of patients, because as we said, there is a problem on fare transporting patients from from Southern Zone to Ocean Road. So if they have the Southern Zone starting giving chemo and radiotherapy, then those people will be treating on their home than coming to Ocean Road. So that's it. Thank you for listening.